Hi everybody, my name is Professor Richard Riley, and this talk was originally scheduled for December, but unfortunately my son got poorly. But better late than never. Thank you for your patience. So this talk is for the Biometrics Seminar 2020 for the IBS Japanese region, and I really want to thank the organisers for inviting me, and in particular to mention Yuzuki, who worked with me for a year in Birmingham, and I hope it's worth the wait, but I really do thank you for waiting for me, and yeah, I hope you get a lot out of this talk. So my talk is on Ibd Meta-Analysis, and I'm going to sort of try and push the boundaries a little bit in terms of where the field is at the moment. So I'm going to talk about some advanced topics and mention some recent debates. So we start with a bit of background. So Ipd Meta-Analysis. So Ipd stands for individual participant data. So we used to call it individual patient data, but obviously people who contribute to research, they're participants. And so individual participant data is a much more inclusive and broader term that's now being adopted. So this is the original raw data from primary studies that we're trying to collect and synthesize. And today I'm focusing on the meta-analysis bit. So, you know, there's maybe a couple of years, maybe even more to obtain and clean data for an Ipd meta-analysis project. But here I'm focusing on the statistical approach to synthesize the data. So an Ipd meta-analysis, you know, formally is the synthesis in sort of some statistical model of the Ipd from the multiple studies for the purpose of summarizing the evidence. You're trying to obtain an overall summary result to provide evidence-based recommendations for practice. And of course, this is hugely relevant in the era of personalized medicine, precision medicine, also known as stratified medicine or stratified care. So here is an example of individual patient data from a hypothetical meta-analysis of hypertension trials. So in comparison to a traditional meta-analysis where you would just have the overall treatment effect and maybe the mean age, the mean blood pressure at baseline and follow-up, here you can see that we've got patient level information. So for example here, patient 1, we see their baseline blood pressure, we see their final blood pressure, we know that they were in the treatment group, we know their age, we know their gender, and we would have other baseline information as well, often hundreds of columns potentially, biomarker values, family history, other things that were recorded by each trial. And we have a row for every single participant in every single data set. So we see here we've got study 1, study 2, study 3, and this is hugely truncated, and of course our data sets will be often massive, containing thousands of rows. Depending on how many participants are in each study. So when we have individual patient data from multiple studies, how do we do the meta-analysis? Well, the most common approach is a two-stage approach. So this is where we obtain the aggregate data using the Ipd from each study separately in the first stage. And then in the second stage, we synthesize that aggregate data using traditional meta-analysis methods. So a inverse variance meta-analysis, assuming a fixed effect, a common effect if you like, or a random effect. So what I mean is, therefore, in the first stage you're doing an analysis to obtain an estimate of something of interest. So typically today I'm going to be talking about treatment effects. So focusing on randomized trials and trying to combine treatment effect estimates or something related to the treatment effect across studies. So if I just get my laser pointer on, you can see here that I've denoted my effect of interest by theta. Theta hat is my estimate, and I denote study. So this is my estimate of the treatment effect in study I, and then these thetas are pooled across studies using a standard meta-analysis. Now you can program this by hand, and in the second stage program this using computer software, and then in the second stage use existing meta-analysis modules that are available, like Metaphor in R or Metan in Stata. But you might not know that there's a fantastic module called Ipd Metan written by David Fisher from UCL, who has automated the first and the second stages in this single package. So in the first stage, it allows you to run various options like regression models, linear logistic, Cox regression, for example, and then it will extract from each study the results that you want and then pull those in the second stage using a whole variety of options to do in the meta-analysis. So I can highly recommend that package. The alternative is a one-stage Ipd meta-analysis. So this is where the individual patient data from all the studies are analysed in one go. So in a single statistical model that accounts for the clustering of participants within studies. So it's a multi-level model, a hierarchical regression model, and this could indeed have mixed effects. So for example, if you had a continuous outcome like blood pressure, and you wanted to do a one-stage model, you'd fit a mixed effects linear regression model. So here I've got my Y, which is my outcome vector, my blood pressure follow-up, and then I've got my design matrix X linked to my main effects, the betas, which contain intercept terms. They contain the effect of adjustment factors. They contain the treatment effect, whatever it is you've included in your model. And then we've got a design matrix Z for the random effects U, and of course the random effects could be placed on any terms to allow there to be heterogeneity across studies. So this could be the intercept, it could be the treatment effect, and often should be the treatment effect given that there's usually heterogeneity. And then we have a error term. So this error term, we'll come back onto this a bit later, but here we would probably want to allow a separate residual variance for each study, so to stratify our residual variances by study. So in a one-stage model, this gives us our summary results, the betas, in a single stage. So many statisticians, by default might think this is a better thing to do. So here is an example. Here I've got 10 trials of antihypertensive treatment, and we want to know what's the overall effect. So on the left-hand side, we can see I've got the 10 trials, and then I've done a two-stage analysis and a one-stage analysis. What we see is that the two results at the bottom here are basically the same. So regardless of how I've done the analysis, two-stage or one-stage, I get a similar sum result of about -10. So the treatment reduces blood pressure by about 10 millimeters of mercury more than the control group, on average across all these studies. There's a lot of heterogeneity, but you can quite clearly see that in every single study, the effect is negative, i.e. the treatment is reducing blood pressure more than control. And one stage and two stage gives very similar results, and that is what we usually see in practice, unless data is quite sparse. I'll come back onto that in a bit. Similarly as well, just to mention it while I'm here, on the left hand side we can see the percentage weights from the two stage and the one stage approaches, and again these are basically the same, and again you'd expect that. So today I'm going to focus on how we utilize these frameworks, the one stage and two stage frameworks, to estimate treatment covariate interactions. So this is typically the focus of an Ipd meta-analysis of randomized trials, that we want to go beyond looking at the overall treatment effect and want to look at the whether the subgroups essentially. And then the second part of my talk is going to come back onto this issue of one stage versus two stage approaches, and give some recommendations about which one is best, and some of the intricacies in terms of when we might expect there to be differences, and why a lot of the push towards a one stage approach is, I think, misguided. Along the way, I'm going to cover a number of other options and other topics which I hope will be of interest to you as well. Okay, let's focus first of all on treatment covariate interactions. So the idea is that we want to go beyond the overall treatment effect because we think potentially that there could be differences in the treatment effect across participants defined by particular characteristics. So this needs us to look at what are called treatment covariate interactions. So subgroup effects, moderators, effect modifiers. These are different names, but really we're looking at interactions. So single studies often have low power to detect genuine interactions. They're not powered, are they, on the interaction? They're powered to detect an overall effect. But with Ipd meta-analysis, we can increase the power to potentially detect interactions if they do exist. So in the last few years, a couple of papers have come out which have tried to clarify how we should derive treatment covariate interactions using an Ipd meta-analysis, because we've seen, and David Fisher and colleagues have seen, that the standards of analysis in Ipd meta-analysis projects is very poor at times, particularly to estimate interactions, and mistakes are being made. So I'm going to draw on this material in the following slides. So of course this relates to the fact that we've got information at the participant level. So let's have a look here again, going back to our hypertension trials. We can see we've got information at the participant level on baseline blood pressure. We've got their age, their gender, and other information as well. We can use that to look at interactions between, for example, gender and treatment effect. And it was an Ipd meta-analysis that first drew attention to the fact that tamoxifen, a treatment for breast cancer patients, works better, or may even just only work in those that are estrogen receptor positive. So an Ipd meta-analysis got these findings here, where in those that are positive, there's a very strong treatment effect, and those that are negative, the treatment effect doesn't seem to be very pronounced at all. So that's an example of precision medicine, where those that are ER positive are more likely to benefit from tamoxifen than those that are negative. And a lot of Ibd Meta-Analysis projects are searching for something like this. They're really trying to find interactions. And to be honest, I don't think they often do exist. But particularly when there's not a biological rationale, which there was in this particular situation. In the next few slides, I'm going to talk about problems when people do analysis to estimate interactions. So first of all, I'll show you how to do it right, and then I'll come on to some issues that have gone wrong for people. Okay, fundamental methods. So in a two-stage approach, the first stage is going to need us to estimate the interaction. So the interaction between the treatment effect and the patient level covariate of interest. And then the second stage, we're going to pool those interactions. So let us denote study by I, participant by J. My covariate of interest I'm going to call Z, and X is going to be my treatment, which I'm coding 1 for treatment and 0 for control. So if we had a continuous outcome, let's say blood pressure again, then we would model let's say an ANCOVA model, where we'd fit the final value, adjust for the baseline value of the covariate, Y0, adjust for the prognostic effects of the covariate of interest Z, let's say that's age, and then we have the treatment effect for those that are of age 0, and then crucially this term here, this is our interaction. So this term here is our key thing of interest. The gamma W term tells us the interaction between the treatment effect and our Z variable. So if you like, how a 1 unit increase in Z, 1 unit increase in age, changes the treatment effect. So in the first stage, we're going to estimate these gammas, and in the second stage, we're going to put them together in a standard meta-analysis. So let's say a random effects meta-analysis. So here now I've got my random effects meta-analysis, and I'm going to put together the estimates of the interactions from each study, and I'm going to assume that they vary the true values vary according to a normal distribution, and I'm going to try and estimate this average interaction effect across studies, and also the amount of between study variability, tau squared, in the interaction effect. Note that I've denoted this gamma by gamma W. So that W is very, very important, because this means that I'm only using within trial information to estimate my interaction. So I'm only using information within trials, the differences between participants within trials, to estimate my interaction. I'll come back onto that in a bit. So moving across to the one-stage approach, how do we also make sure that we only estimate interactions using within trial information? Well, unfortunately, most people don't think about this, and so what they do is they put an interaction term in their one-stage model. But that isn't sufficient, because what that can do is it can bring in both within trial and across trial information. Because don't forget, in a one-stage model, you've got two variance terms. You've got variance at the participant level, and also got random effects that are explaining heterogeneity, variability across studies. So if you include a term simply like that, you can explain both sources of variation, and that leads to an interaction term that's an amalgamation between within trial and across trial information. To address this, we need to do either one or two things. Firstly, we need to stratify, I'll just put my laser pointer on, we just need to stratify every single nuisance parameter by study. So for example, if you've got 10 trials, you need to estimate 10 intercepts, 10 beta 1s, 10 beta 2s, 10 beta 3s, and then we can synthesize and get an average treatment covariate interaction. The other way of doing it is to center the covariate by its study specific mean. So to center the covariate by the study specific mean, and also include a term for the mean covariate in the model as well. Here in this equation, what I've done is I've actually stratified nuisance parameters by study and included the covariate and the interaction term centered. But even if I didn't do that centering here, it would still give me the same answer because of stratifying every other term by study. So this approach disentangles within trial and across trial information, and you end up with the interaction estimate here, which I've assumed is heterogeneous across studies, and therefore I've got this summary of the random effects distribution, gamma W. So again, the W is to denote within trial information. So let's go back to our hypertension trials analysis. Remember, before we had this result of about -10, that the treatment is very effective compared to control at reducing blood pressure. The one-stage and two-stage results were very, very similar. But the question then remains, it's okay, it works on average, but does it work equally according to patient level characteristics? So let's say for simplicity, let's look at gender. So is there a difference in the treatment effect between males and females? So that means we need to estimate a treatment-sex interaction. So this is what I've done in a two-stage approach, again using the Ipd Meta module in Stata. So in every single trial, I've estimated the interaction between sex and treatment, and we see that there's a very, very small difference in the treatment effect between males and females in every single study. So if we look, there's very little heterogeneity, and also that the overall treatment covariate interaction is 0.77. So that means that the difference in the treatment effect between males and females is 0.77. So it works slightly less well for males compared to females, but it's tiny on the blood pressure scale. And the confidence interval overlaps the null value of 0. There's no evidence here of any statistical or clinical difference between the treatment effects for males compared to females, as we might expect, because what's the biological rationale for that? The one-stage approach on the previous slide, where we stratify nuisance parameters by trial and estimate our interaction with a random effect, gives you exactly the same answers. So that's all very well and good, but what about how we get things wrong? And I've already alluded to this, but there's a lot more other ways we can get things wrong as well. So 7 learning points. The first one is when we're doing Ipd meta-analyses to examine interactions, don't perform a meta-analysis for each subgroup and then compare their results. So what people tend to do here, for example, is they do a meta-analysis for males and then a meta-analysis for females, and then they compare the results. But again, this, although it seems simple, it's really problematic because you're allowing a cross-trial information to come into play. For example, an extreme situation, you may have a trial that only had males recruited, and if you do the separate subgroup approach, that trial with only males would still contribute to the meta-analysis result for males, and therefore it would contribute to any comparison between the meta-analysis result for males and females. But of course, if you were doing the approaches that I've recommended, where you use only within trial information to compare males and females, then that trial that only had males could not contribute to that and would be excluded. It has no information within trial at the participant level of the difference between males and females. So for example, if we did a separate subgroup approach to the hypertension example, we get that for males the treatment effect was -9, for females it was -10.6, a difference of 1.57. Well, that's quite different, although potentially not clinically important, but it's still very different numerically from the result that we got properly on the previous slides of 0.77. So that's just one example of how much different it can be. Second learning point is going back to what I was talking about one-stage models and the fact that people don't separate out within trial and across trial information. So what people tend to do is just include an interaction term here, as I've got it on the screen, and there's no stratification by study, there's no centering of covariates, and what we end up with is a amalgamation of the within trial and the cross trial information. So this gamma I've now labeled gamma WA within and across. So it seems again simple, but it really could be potentially wrong because the across trial information can be hugely biasing the results. So what I mean by across trial information is the information coming from like a meta regression. So if you didn't have IPD and you were looking at the association between treatment effect and gender, you would perhaps only have the percentage male in a study. So you'd be able to do a meta regression of the overall treatment effect and how that changes across studies as the percentage male changes. Well, that relationship is hugely subject to confounding. So those studies with a higher percentage male may have the lower dose of the drug. So is it dose? Is it the percentage male that's the cause? We don't have that within the same trial. So meta-regression is hugely problematic, and this is called aggregation bias or ecological bias. And we want to try and avoid that. We've got the IPD, so let's do what we can to avoid it. It naturally avoids it in a two-stage approach, but doesn't naturally avoid it in a one-stage approach unless you do the recommendations that I said. So let's have a look at the results again for the hypertension example. Is there a treatment age interaction now? So looking at age, well, we see that if you did the amalgamated analysis, which is, I would suggest, is the wrong analysis, you get a significant result, statistically significant result. However, there's far less evidence of an effect when you do separate out within trial information. So the effect is halved, confidence interval is much wider, and there's no clear evidence of an interaction with age. Learning point 3 is to not dichotomize continuous covariates. And of course, this doesn't just apply to Ibd Meta-Analysis. This is a general issue in medical research, I think, where people naturally feel they should categorize continuous covariates, and particularly dichotomize them. But this is very well known. I'm not going to go on for this for too long, but you're throwing away so much data because on the continuous scale, when you analyze things, you've got much more power to detect intricate changes. It's also more biologically plausible that an effect, if there is an effect, would change slowly and incrementally and not suddenly dramatically shift by some cut point value that's with no biological rationale. We've seen examples where throwing your IPD, by dichotomizing your continuous covariate is similar to throwing away about 33% of your IPD. So if you take 2 years to do your data collection for your project, it's like wasting, about 7 or 8 months of your life, just throwing that away to get the data. Not good. Let's go back to a different example. This is an example looking at interventions to reduce unnecessary weight gain in pregnancy. And we got 32 trials to do an Ipd Meta-Analysis. And we looked to see if there's an interaction between treatment and age. And if we analyze age as a binary covariate, we get an interaction of 1.14, quite a wide confidence interval, no clear evidence again. But looking at age on a linear trend, then we see that there does seem to be much stronger evidence of a relationship between age and the effect of interventions to reduce unnecessary weight gain. So again, you could potentially miss something that's important if you start dichotomizing your continuous variable. A related point is that we shouldn't dichotomize our continuous outcomes. So sometimes when we have blood pressure, people may dichotomize that into high and low, for example, but again, that's losing information and not something that I would recommend. A related point is that our interactions with continuous covariance may be non-linear. So that means that instead of just assuming there is a linear relationship, so that the effect on the treatment's effect is changing at the same rate as we move across the continuous covariate, no matter where we move, actually it means that in some ranges there may be more granular or slower changes in the treatment effect than in other ranges. How do we do this? Well, we need to model nonlinear relationships. So we could use polynomials or we could use splines. Personally, I prefer splines here. So this leads to, in a two-stage approach, us needing to do a multivariate meta-analysis. So what I mean by that is that in the first stage, we now estimate a multiple terms defining our spline function and its interaction with treatment effect. And in the second stage, we take the multiple parameters of that function and combine that in a multivariate meta-analysis, which accounts for the correlation amongst those multiple parameters. Key thing is to, through visual inspection, choose not positions that are sensible and the same in every study. If they're not the same in every single study, this approach doesn't work. You have to fix the not positions to be the same in every single study. And ultimately, the summary will lead you to give a summary curve and not a summary estimate. So let's go back to our hypertension trials and we see whether there's a relationship between age and the treatment effect on blood pressure. And I'm going to choose a reference group of 55 years old. And what we see here is that and the dotted lines represent my confidence interval and this solid line is my summary curve. We see that actually as you become younger, people that are younger than 55, the treatment effect is slightly not as good, so it's positive, so the reduction in blood pressure compared to control is not as strong. And then after about 55 or 60, it seems to plateau quite a lot and there's not much difference. So the treatment effect seems to be slightly better, and there's strong evidence of that through the confidence interval here. You know, the older you get, but after around 60, there doesn't seem to be much additional benefit. Learning point 5 is that a treatment covariate interaction may exist even when there's no heterogeneity in the overall treatment effect. Sometimes when people do a traditional meta-analysis, what they do is they find heterogeneity in the treatment effect. They say we need to do an Ipd Meta-Analysis because there must be something that's causing this at the participant level. Well, that's just not necessarily a good way of thinking, because heterogeneity in the overall treatment effect is a very poor indicator of whether interactions exist, because it depends on the distribution of covariates across studies, whether interactions are linear or nonlinear, and other factors. So you may have an interaction that exists when there's no heterogeneity, and there may be no interactions even when there is heterogeneity. So don't use heterogeneity as a marker for whether you should do an Ipd meta-analysis or not. So for example, let's go back to the hypertension data, and we examined whether hypertension treatment has a beneficial effect on the rate of cardiovascular disease, so time to event outcome. When we looked at the overall treatment effect across all participants, across all studies, the summary hazard ratio was 0.74. So clearly there's a reduction in the rate of cardiovascular disease if you're taking antihypertension treatment compared to control. However, tau squared was 0. So there's no observed heterogeneity here. So you might look at that and go, well, it's very clear, therefore, that this treatment works consistently well for everybody. But heterogeneity relates to heterogeneity at the study level, not the participant level. So we examined whether there was an interaction. Learning point 6 is that the treatment may work for everybody, even if a treatment covariate interaction is there. So this is just a reminder that if there is an interaction, it doesn't mean to say that then we can only apply the treatment to some people and not others. So it could be that it works for everybody, it's just the magnitude of the effect changes. So here I'm plotting the benefit of hypertensive treatment on blood pressure, conditional on age. Remember earlier we said that there looked like there was a nonlinear relationship between age and blood pressure. Here I'm seeing that when we model our interaction properly without ecological bias, we've got this black line, and we see that the treatment effect, my predicted treatment effect for age, it goes from about -6 when you're about 30 to about -11 when you're about 60 and about -9 when you're about 100. Interestingly, if you did the wrong analysis and you didn't separate out interaction terms within the cross studies, you would end up with this lighter shaded grey colour, which is more pronounced. I mean, that's because it led to a more extreme effect, if you remember. So my predicted treatment effect, conditional on the interaction, is beneficial for everybody. It's all negative, even though the interaction is there. My final endpoint is that just to say that when you're planning an Ipd Meta-Analysis project, it is a massive undertaking. When we've done them, 18 months, 2 years is very common for getting and cleaning the data and, just getting to the point before analysis. So, it needs to be something that you're sure is worth the investment, and funders also will want to know that as well. So that raises the question about whether you think the Ipd Meta-Analysis project is powered for the purpose of your research. So if you've got information about trials in advance of the Ipd collection, such as the overall treatment effect, the covariate distribution, so the mean age, the variability of age, the number of participants in each trial, then we can use that information to actually do a power calculation. So in a paper with Joey Ensor, we looked at this, but also looked at this by simulation-based approach, but also there's some, for continuous outcomes, there's some closed form solutions originally proposed by Simmons and Higgins. We extended this work to allow for different residual variances per study. And what we see here, I'm not going to go into the calculation itself, but the variance of your overall summary estimate is a function of the residual variances in each study and the variance of the covariate in each study and the sample size. So we can use that information that we can maybe obtain from study authors or study publications and feed that into our equation to get an estimate of what the variance would be, and we can use that then to work out what the potential power would be, conditional on assuming some magnitude of interaction. So going back to the pregnancy example, before we did the Ipd meta-analysis, 24 trials had promised their individual participant data. So we could have asked the question, is that adequate? So is it adequate to detect a 1 kilogram larger treatment effect for a 10 unit BMI change, for example? So when we use the information contained within these equations, we extracted it from studies. The simulation-based approach gave an 83% power. This closed form approach gave 84% power. So that would have been reassuring to know in advance of doing the Ipd data collection that if we get this data and are able to clean it, all these things, then we would be able to have quite high power to detect an interaction between BMI and treatment effect, if indeed it existed. Okay, I hope you're still with me, and that we are now going to go on to part 2, which is looking at the differences between one-stage and two-stage methods. A review a number of years ago by Mark Simmons looked at the previous 10 years of Ipd meta-analyses and concluded that much has changed, and one of the things that had changed most of all was that many researchers are switching from two-stage methods to a one-stage method where all the Ipd are combined together in the same analysis. And they suggest this is probably due to growing familiarity with these methods, improved software, and recognition that one-stage models offer the greatest flexibility. So I just want to sort of challenge that in terms of encouraging people to, if they're unsure, then in most situations a two-stage approach is probably better for them. The reason for that recommendation is that usually the results from a one-stage and a two-stage meta-analysis are going to give you the same, identical, very similar results. So many theoretical and empirical papers say that the estimates are similar, so there's some references there to look at. Remember the hypertension example earlier? We used REML estimation in both one-stage and two-stage. We stratified in the one-stage all our nuisance parameters by study. We used a random effects meta-analysis in both analyses. We get basically the same results. So there's no difference in one-stage and two-stage. Now, two-stage methods are much more familiar to a broader set of researchers, typically fitting a standard, quite simple regression models in the first stage and then standard well-known meta-analysis methods in the second stage. One-stage method is much more complicated, and I'm just saying to you there, stratify by study. Well, people may not understand what that means. You have to estimate multiple parameters together. You've got to put random effects on terms, and these things can lead to mistakes, and this leads to problems. And it's much easier to make mistakes in a one-stage analysis than a two-stage analysis, in my experience. So based on that, the approaches give you very similar results. In practice, you may not see results that are the same, but this is not because of choosing a one-stage or a two-stage per se. What it actually is about is that people are making different assumptions. So for example, in a one-stage analysis, some people would put a random effect on the intercept. Well, that is an assumption, and it may borrow information across studies and therefore lead to different answers. They may use different estimation methods. So, you could use a REML in a two-stage and a maximum likelihood in a one-stage. Well, they're different methods. REML's often better. You're going to get different results potentially. Confidence intervals may be derived differently from the two approaches. So it's not the one-stage or two-stage per se, it's the actual process of estimation and the assumptions that you're making as a researcher. I'm going to focus on 5 reasons why differences may arise. Further details are given in a paper by Burke et al. In 2016. This is the paper by Burke et al. If you want to go away and read it a bit more. So the first reason is why may you get a difference between a one-stage and a two-stage? The first reason is that in situations where the data are sparse, so where the outcome is rare or where the number of participants is quite few, then a one-stage method is preferred. So in that situation, I do prefer a one-stage method. The reason is that a two-stage approach, usually in that situation, has problematic assumptions that arise from the first stage having sparse events. So in the first stage, you would need to estimate your treatment effects. Now, if you have 0 events, you'd need to do a continuity correction, and that's perhaps a little bit arbitrary, leads to bias. The second stage also assumes that your estimates have known variances. Well, when the data is small, the variances are estimated with a lot of uncertainty, and so that will be implausible as well. However, one-stage approach completely doesn't have to do any of those things because you analyze the data exactly. So for example, if you've got binomial data or Bernoulli data, you can model that distribution. And so you don't have to estimate the treatment effects in each study. You're actually modeling the count data itself and the underlying distribution exactly. And then all you're doing is in the same model where you're making those exact likelihood assumptions, estimating the average across studies. So you avoid that first stage and the assumptions that come with that. So in that special situation where the number of studies, where the studies are mainly small, then I would recommend a one-stage approach. However, that's quite a specific situation. In most situations, even if you have 1 or 2 studies that have sparse events, you would have other studies that are bigger, and therefore they dominate anyway, and those smaller studies have little impact. So it's really only when the majority of the studies are small, for example, when you've got rare diseases and rare outcomes. Further reading about that is by Hamza et al. Here's an example from their paper. Here's going away from treatment effects. This is looking at a diagnostic test result. Here's the sensitivity of a test. I've got 9 studies looking at the proportion of those that are diseased that were tested positive. And we can see that there are some studies with 0 false positives. So for example, study 8 here, 21 true positives out of 21 truly diseased. So that, to estimate something in the first stage, would need a continuity correction. In a one-stage approach, you don't need that. This leads to differences between the results from the meta-analysis. So if you did a 2-stage meta-analysis of the logit sensitivities, you would get this summary result here, 1.71 on the logit scale. But a 1-stage meta-analysis gives you a summary result of 2.20. So when you transfer that back, it's a difference in sensitivity of about 5%. And so this is because of the issue of sparsity of data in each study. So that's the key reason why you may get a genuine difference between a 1-stage and a 2-stage that is of key interest and where a 1-stage is preferred. In the second reason, we're now moving to things that are impacted on by the researcher. So the choice of nuisance parameters, for example. So in a 2-stage approach, like I said, every single nuisance parameter is automatically stratified by study. So your baseline risk, your residual variances, your adjustment for prognostic factors is all stratified by study because you analyze each study separately. In a 1-stage approach, to mirror the 2-stage approach, you must specifically estimate a separate term for each study for those nuisance parameters. For example, your residual variances need to be stratified with an I here. But software by default won't do that. So, for example, the residual variances will naturally be assumed to be common for every single trial. So you have to, as a user, go beyond what it's automatically doing and stratify terms. So let's have a look at that. Let's go back to the hypertension data and look at the treatment effect on systolic blood pressure. A 2-stage approach gives you a minus 10.17 treatment effect. And we get this tau squared here. The 1-stage approach, we do a different residual variance. We get minus 10.16, basically the same results. And that's expected. We use the same estimation method, stratify parameters, everything's the same, we get the same results. If you didn't stratify the residual variance, then you would get slightly different results. So minus 10.34, a larger tau squared estimate. So the difference here is not because you're using a 1-stage method, it's because you're changing your assumption that the residual variance is now assumed to be the same in every single trial. Another key reason is the different estimation methods for tau squared. So 1-stage and 2-stage methods allow you to have different estimation methods. You may also get convergence issues in a 1-stage model. Now, 1-stage models for binary and time to event outcomes will typically use maximum likelihood estimation, and this underestimates tau squared. In a 2-stage approach, we would typically use REML in the 2nd stage to address that. But 1-stage models, many 1-stage models do not have maximum likelihood estimation options, particularly for non-continuous outcomes. Do not have restricted maximum likelihood options, I should say. So another related issue is that in the 2-stage approach, the traditional method is the disseminated and layered method, which is not available in the 1-stage approach. So these things, these different options, will lead to differences in the results. A further complication is that the treatment coding, so the way you code treatment, can also influence the results. I'll come on to this in an example. So first of all, focus on the 2 top things. This is looking to see the effect of hypersensitive treatment on systolic blood pressure. If I do REML analysis in the 1-stage and the 2-stage and stratify all my terms by studying the 1-stage, like we said before, you get exactly the same, basically exactly the same result. However, if I'd now done maximum likelihood estimation and not REML, again, I would get differences to the REML results, My tau squareds are lower because maximum likelihood has more downward bias in tau squared. But also I'm actually getting some differences between the 2-stage and the 1-stage. So my 2-stage gets 5.84 for tau squared, my 1-stage gets 4.94. Now the reason for that is that the maximum likelihood estimate in a 1-stage model is more downwardly biased than the maximum likelihood estimate in a 2-stage model. Because in a 1-stage model, you're estimating more parameters, and those more parameters lead to more downward bias. And hence you get 4.94 compared to 5.84, and they're both lower than these two. How do we deal with this? Well, in a 1-stage analysis, what we found in recent work that we published in Statistics in Medicine is that if you change the treatment variable coding so that it's centered by the proportion who are treated in that trial, then this reduces considerably the downward bias in the maximum likelihood estimate, and indeed makes it comparable to then the maximum likelihood estimate that you get from a 2-stage analysis. So this is our recommendation in that paper. We say when using maximum likelihood estimation of a 1-stage model with a stratified intercept, the treatment variable should be coded using study-specific centering, as this reduces the bias in the between study variance estimate compared to using a 1-0 coding and other coding options. Okay, so this is something a bit blows your mind, but it's related to the fact that you're disentangling the other parameters from your estimation of your variance term. Let's have a look at this at the bottom. So the results are as before, but now I've added in maximum likelihood estimation with no centering of the treatment variable. And this is what we had before, isn't it? But now if I center, I get minus 10.09 and 5.87. So this result here at the bottom is now basically the same as the 2-stage analysis when I'd used maximum likelihood estimation. So again, it's just an illustration of how there's some nuances between 2-stage and 1-stage, which most people, I guess, will not really understand. But it's to do with the user, their specification, their assumptions, their estimation methods, and even their coding options. And it's quite frightening, and hence why, encouraging you to think about the 2-stage more often. Fourth reason is accounting for correlation amongst model parameters. So does the model account for correlation? Well, a 1-stage model naturally does, particularly if you account for repeated measures and time points at the same time. A 2-stage model doesn't in the 2nd stage, because we normally just put one parameter together, unless we use what's called a multivariate meta-analysis. And I talked about a multivariate meta-analysis earlier when I was mentioning the spline function. But this is particularly relevant when dealing with longitudinal outcomes. So if you're looking at treatment effects at multiple time points, then you're going to get some studies which don't give you all the time points. Now, a 1-stage analysis would handle that more naturally than a 2-stage analysis would do. So if you do a separate analysis at each time point in a 2-stage, you will get to differences to a 1-stage analysis which accounts for all the time points together, because the 2-stage approach isn't accounting for correlation, but the 1-stage approach is. So we looked at this in 2009. This paper was published looking at repeated measures models, and we looked at 12 time points and treatment effects at from 1 month to 12 months. This is the results from a 1-stage approach that accounts for the correlation amongst time points. This is the results from a separate 2-stage analysis at each time point. So we see that some very big differences. For example, here minus 0.48 compared to minus 0.84, minus 0.02, and here's plus 0.29, so even a different direction. Well, this is because you're making different assumptions. The first 1-stage model is allowing for all the time points together and is handling the missing outcome data in a hierarchical model. This approach is not doing that. But if we were to extend to a multivariate meta-analysis, then we get this. We get the 2-stage results, which are basically the same as the 1-stage results, almost identical again. So again, if we make the same assumptions, we get the same results from a 1-stage and a 2-stage, unless the data are sparse. So in summary, If you're making different modelling assumptions or you're using different estimation methods, then you're going to get some differences between one stage and two stage. And that's not because of one stage and two stage approach, it's because you're changing the assumptions and the estimation methods. If you make the same modelling assumptions, the same estimation methods, and you were to use the same sort of approaches for getting confidence intervals, then you would get basically the same results as I've shown you in many examples so far, unless the data are sparse. So the major benefit of a one-stage approach is when there are rare events, because then the exact likelihood is more important to use because those assumptions in a two-stage approach are not very good at all. But this is no panacea, this is no foolproof approach, because even then you would be using maximum likelihood estimation in a lot of situations and really would need REML. So there's still concern of downward bias in some situations. There are approaches to use REML using pseudo likelihood methods in one-stage models, which we talk about in the Statistics and Medicine paper. Briefly, other reasons why you get differences between a one-stage and a two-stage approach is the one-stage approach uses stratified intercepts or random intercepts. If you choose random intercepts to account for clustering, then that might lead to differences to the two-stage approach, which stratifies. A two-stage approach, how you derive your confidence intervals, people tend to recommend the Hartung-Knapp, also known as the Hartung-Knapp-Siddick-Yonkman approach to deriving confidence intervals with t-distributions. In a one-stage method, that isn't available, and you might want to use a Kenwood-Roger or a Satterthwaite approach to deriving confidence intervals. If you don't adjust for ecological bias, aggregation bias in a one-stage model, but you do in a two-stage, that will lead to differences, as we discussed earlier. And just to finish, just to mention this paper by Evan Kontopantelis, which is a very detailed and extensive simulation study, which is a very comprehensive piece of work. But just to note that one of his recommendations says that basically that a one-stage model should be preferred, especially when investigating interactions. But I just want to push back on that particular recommendation because his simulations did not allow for study level confounding, and therefore there were no differences between across trial and within trial interactions. In reality, that could well happen, and therefore he is inflating the benefits of a one-stage model there because you're going to get more power. So we don't agree with his recommendations for a one-stage model with interactions unless you censor your covariates, but then you get similar answers to a two-stage, as mentioned there. So what do we recommend one stage, two stage? So here's our general approach. Ask yourself, are most studies small? If the number of participants is less than 20 or 30 per trial, or the events is, let's say, less than 10 to 20 per trial, then yes, use a one-stage approach. This is more exact and avoids the assumptions of normality and known variances in a two-stage approach from the first stage. Otherwise, you can choose whichever one you like. We prefer the two-stage approach because it makes sure that helps people do the right things. So it stratifies nuisance parameters. It allows you to get study-specific estimates, forest plots, nice graphical displays. It can create percentage study weights. You can use estimation methods like REML in the second stage with Hartung-Knapp confidence intervals. If you're in doubt, why not specify that you'll do both a one-stage and a two-stage, and you should get very similar answers unless the data are sparse. And if you don't, it's probably because you are making different assumptions in a one-stage than you are in a two-stage, and that'll be a good flag for you to check that. So to finish, let's go back to the hypertension example. This is where we started, it's where we'll finish. So all studies were large, hundreds of patients in each trial. I'm going to use REML estimation in both one-stage and two-stage approaches. Therefore, I expect there to be the same results. I've stratified nuisance parameters in the one-stage results model as well, and so I basically get exactly the same results. However, here's an example from Simmons with 7 trials, And we see that in these trials, in most of the studies, the number of events here is very few. So we have less than 10 events for every single trial, some 0 cells as well. There I would not be comfortable doing a two-stage approach, but I would want to use a one-stage approach, and I would want to, because I'd have to use maximum likelihood estimation, I would want to center my treatment variable. If I did that, I would get an odds ratio of 1.91. If I didn't and use a two-stage approach, I get a very different result of 1.31. Okay, so the one-stage approach is better there. And I'm saying it's better because of theoretical reasons, not because I'm looking at the results and seeing a difference. It's known theoretically from the papers that I've mentioned earlier. So in conclusion, thank you for listening to this talk, and I hope it's been informative. I've covered a lot of different topics. One of the reasons for this talk is that there are many issues in an IPD meta-analysis at the moment. People are doing the wrong things, and this can lead to the wrong conclusions and potentially even the wrong stratified medicine. So for interactions, if that's your focus, then aim for using within trial information and handle continuous covariates appropriately. Generally, we recommend the two-stage approach is fine. One-stage methods are important, but they tend to be overinflated in terms of their importance. And actually in practice, particularly with people who are not experienced in these methods are using them, they lead to a lot of errors. So unless studies are sparse in terms of their data, then I would suggest that most people use a two-stage approach. And if you are using a one-stage model, then think about centering your covariates, because then your estimates of tau squared will be less biased in a maximum likelihood estimation framework than if you didn't. And I will leave you just with a bit of information that you may be interested in. Here's references to some papers. The one highlighted at the top is actually our new book, Individual Participant Data Meta-Analysis, a Handbook for Healthcare Research, which is coming out in May this year, published by Wiley, with fellow editors Jane Cherney and Leslie Stewart, who you probably also know have got huge experience in the IPD meta-analysis field. And that book will have 18 chapters covering the whole process, not just the statistics, but the whole process of setting up your study, collecting and cleaning the data, examining their quality, harmonizing it, and it will focus on trials and also prognostic and diagnostic studies and risk prediction, and cover special topics such as network meta-analysis and missing data as well. So that will hopefully be a really good book for the field going forward. Also to note that we have some courses at my university in the UK. In this next few months, we will start doing those courses online for obvious reasons. And we have courses in risk prediction modelling, IPD meta-analysis and prognosis research that you may be interested in. Those courses are available to look at online at prognosisresearch.com. This is a new website that myself and Kim Snell from Kiel have put together to try and improve the standards in prognosis research. So I hope you might have a look at that as well. But thank you very much for listening, and also again, thank you for your patience waiting for this talk, and I wish you all the very best.